Which of the following findings is most likely to be seen in this patient's HRCT? Okay. A 55-year-old woman with a history of rheumatoid arthritis presents to her primary care physician with a 3-month history of progressive shortness of breath and a dry cough. She has not experienced fever or chills. She denies any recent travel or exposure to sick contacts. On examination, her vital signs are stable and her lungs revealed by basilar crackles. HRCT is chest is performed. Which of the following is most likely to be found? Man, I do not. I struggle with lung diagnoses. So I think the big thing here is that she also has rheumatoid arthritis, which I mean
Okay.
is an autoimmune condition. Um, doesn't to me, I just think that's supposed to help. To me, it really doesn't. Um, she denies any sick travel. Bronchiectasis, I always think smoking.
Okay.
So I'm gonna get rid of bronchiectasis. A large pleural effusion would not be a 3-month history. A 3-month history. This is a large pleural effusion would be a very acute issue, in my opinion. Like
Okay.
you just have like fluid in your lungs. Yeah, it's going to be a big issue. So I'm going to get rid of that. Nodular infiltrates or tubular opacities or ground glass. By basilar crackles, I would probably end up going ground glass opacities. I can't make a diagnosis here.
Okay. Final answer.
Yes.
Okay, good. So it's kind of interesting here. So rheumatoid arthritis is autoimmune disorder, as you already know, right? So in my mind, I'm thinking, okay, so always when it comes to these lung things, I'm thinking, okay, so restrictive or obstructive. You're always thinking that, okay? I always bring it back to that. Anytime you get a lung question, I'm thinking of that for pathology. So in this
Mm.
case, right, anytime you get an autoimmune disorder, just imagine that your lung parenchyma is probably, if they're asking you about lung symptom and they give you an autoimmune disorder as a history, then your lungs are probably going to be attacked like parenchyma wise and scar down. And if it scars down, it looks like a restrictive lung issue. Does it make sense what I'm trying to say?
And I would
So
have probably assumed that given like, yeah, okay, I would have assumed that probably, yes.
exactly. So going with this, right? You're like, okay, it's probably restrictive, right? That's why they give you an autoimmune disorder, and the one that's going to support restrictive lung disease the most is your ground glass opacities, right? Which gives you an interstitial lung disease, which is a restrictive lung disease. Bronchiectasis usually, right? Usually going to be more of an obstructive thing, right? Chronic productive cough, smokers, etc. Right? Obviously, you can get it with cancers that back up, or you can get it with pneumonias, infections, things like that. Lower pleural effusions, right? That's going to be dealing with a couple things. Heart failure, pneumonia, malignancy too can cause you that. Nodular infiltrates, right? Sarcoidosis, TB, or malignancies can give you this, but not classic of rheumatoid arthritis associated interstitial lung disease. Tubular opacities are not specific. I mean, I don't even know what tubular opacities mean, but
Honestly, I don't know what that means
yeah.
either.
So, yeah, best answer here is going to be B.